Active surveillance or brachytherapy? If you've just been diagnosed with low risk prostate cancer, somebody has probably said both of these words to you. Those words sent you straight to the internet, and the internet probably made things worse. I'm Dr. Ajay Bhatnagar. I'm a radiation oncologist, and I've treated over 15,000 men with prostate cancer. In this video, I'll show you exactly what the evidence says about these two paths and why one of them sounds safer than it is. By the end of this, you'll know how to tell the difference between a real active surveillance plan and one that's just waiting. That's the thing that determines everything here. Most men don't know it until it's too late. Let's start with active surveillance, because it deserves a fair hearing. This option has real rationale. If your doctor brought it up, he wasn't wrong to do so. Here's the core idea. Some prostate cancers, especially low-grade ones, grow so slowly that they never cause a problem in most men's lifetimes. Prostate cancer isn't all one thing. A Gleason 6, very low volume, caught early in a man who's 75 is generally different from a Gleason 7 in a man who's 58. Active surveillance is designed for that first case where the cancer is so minimal and the man's life expectancy relative to cancer's likely growth rate that monitoring makes more sense than treating. And the reason to avoid treatment isn't nothing. Surgery for prostate cancer carries real risk. External beam radiation runs 40 to 45 daily sessions. Those are real trade-offs. If the cancer is low risk and unlikely to progress, skipping that disruption is a legitimate choice. That's what active surveillance is built for. So the appeal is real. The rationale is real. The problem is the gap between what active surveillance is designed for and how it's actually practiced. Here's the piece of data most men on active surveillance have never been shown. 75% of men on active surveillance eventually require active treatment. 3 out of 4. That number changes what active surveillance actually is. For most men, it's a delay. And the critical question is what happens to the cancer during that delay. The honest answer is that it depends on whether your surveillance plan has a defined trigger threshold. That means a specific written point where a rising PSA or a changed biopsy result means it's time to treat. Most active surveillance plans don't have one. Your PSA can rise, your biopsy can come back more aggressive, and there's no written threshold that says this is the line, and when we cross it, we treat. Here's what a real trigger threshold looks like on paper. It's specific. Something like if your PSA velocity exceeds 0.5 nanograms per milliliter per year, we biopsy. If the next biopsy shows a Gleason grade upgrade from 6 to 7, or if more than 2 cores are positive, we move to treatment. Those numbers aren't vague goals. They're decision points. And your doctor should be able to hand you a sheet that names them before you leave the office. If your surveillance plan doesn't have written numbers, your oncologist can't define the stopping point. That gap is where cancers change grade before anyone acts. I treated a man named Steven. He was 79 when his doctor diagnosed him with a very low risk prostate cancer and put him on active surveillance. His PSA rose slowly over the years. A new biopsy came back showing Gleason 8. Gleason 8 is aggressive. He started watching a low risk cancer and ended up with a high risk one. By that point, his options had narrowed. He didn't want daily radiation, and he didn't want the side effects of hormone therapy. But he was still able to get brachytherapy in office under local anesthesia, and he drove himself home. His brother had been my patient the year before. Steven's story is common. The cancer didn't stay low risk because nobody was watching. Nobody had told him where the line was. If you're on active surveillance right now and you don't know your trigger threshold, ask your doctor today. Ask, at what PSA level do we stop watching? At what biopsy result do we move to treatment? If there's no specific number in the answer, you don't have a surveillance plan, you have a waiting room. If you're on active surveillance right now, I want to know in the comments, whether your doctors gave you a written threshold for when watching stops and treatment starts. Once you understand that 75% of men on active surveillance end up needing treatment, the next question is whether there's a treatment that doesn't carry the disruption and side effects that made active surveillance appealing. Brachytherapy is that treatment. LDR brachytherapy, which stands for low dose rate, is a one-time procedure. It takes about 30 minutes. You go in that morning, you go home that afternoon, and most men are back to their normal routine the next day. There's no hospital stay. Here's what happens inside the procedure. Small radioactive seeds, each about the size of a grain of rice, go directly into your prostate. They emit a low, continuous dose of radiation from the inside over the following weeks and months. Your prostate gets a high, targeted dose. The surrounding tissue, your bladder, your rectum, gets very little. The seeds stay permanently, but they lose their radioactive over time, over several months. They become inert. The cure rate for low and intermediate risk prostate cancer with brachytherapy is above 98%. Surgery and external beam are closer to 95% for the same population. That's not a small gap when you're talking about a cancer diagnosis. The procedure that takes 30 minutes one time outperforms the surgery that requires weeks of recovery. And the side effect profile is different in ways that matter. After brachytherapy, about 76% of men who had good sexual function before the procedure keep it. After prostate surgery, 65% of men deal with permanent impotence. Incontinence after brachytherapy is negligible, much lower than after surgery. The short-term side effects of brachytherapy are urinary frequency, some urgency, and some burning for about 1 to 3 months while the seeds are most active. That's real. It's annoying, but it's not disabling, and it resolves. Now, I want to specifically talk about intermediate risk prostate cancer because this is where the comparison gets even more striking, and most men don't know these numbers. If you have intermediate risk prostate cancer and you go with external beam radiation, your doctor pairs it with ADT, which stands for androgen deprivation therapy. Basically, it's hormone suppression. The standard course can run anywhere from 6 months, even 2 years. With brachytherapy for intermediate risk prostate cancer, men don't need ADT at all. The only cases where we use ADT in brachytherapy is for the high and very high risk patients, where we call triple therapy, combining external beam plus brachytherapy in 6 months of ADT, not 2 years. And the cure rate with triple therapy is 92%, not 65%. 2 years of hormone suppression versus 6 months and a 27 percentage point gap in the cure rate. That's the difference between 65% and 92% for high-risk men. That gap alone is a reason to ask whether brachytherapy is on the table. Now, ADT has real side effects, and they're worth naming because most men aren't told about them up front. It causes hot flashes and kills libido, and over time it leads to fatigue, weight gain, muscle loss, and in many cases, long-term impotence. Those aren't mild inconveniences. For an active man who golfs, works out, and has a marriage and a sex life he wants to keep, 2 years of that is a serious cost. 6 months is still a cost, but it's a very different cost. The one limit worth knowing. Brachytherapy requires that the prostate be under a certain size. My limit is 60 grams. Most men have prostates between 30 and 40 grams, so the majority of men qualify. If your prostate is larger, there are approaches to shrink it down and make you a candidate. So it's worth knowing your size before you assume you don't qualify. I had a patient named Michael. He was 68, newly retired, diagnosed with high-risk prostate cancer. His oncologist told him he'd need 2 years of ADT alongside radiation, and that he'd be impotent for life, and that the cure rate was about 65%. He came to see me. We did triple therapy. 6 months of ADT, external beam, and brachytherapy. His cure rate with that approach was 92%. Within a year, his hormone levels had recovered, his energy was back, and he was living without restrictions. He told me the choice that mattered most was knowing those numbers before he decided. I had a patient named Ricky, a 59-year-old fitness trainer in Atlanta. Elevated PSA, early stage diagnosis. He was on active surveillance and his PSA kept rising. His surgeon told him surgery was the only real option. He flew to Arizona, had brachytherapy, went back to his active lifestyle, and his cancer is gone. One visit, one morning, a 98% cure rate with most of his quality of life intact. For most men with low-risk prostate cancer, brachytherapy is the better choice because it produces a cure, not a watch. Active surveillance is the right call only when three things are true at the same time. The cancer is truly minimal, meaning very low Gleason and a very small volume. A specific PSA level or biopsy finding is written into the plan as the trigger to treat, not something vague the doctor keeps in his head. And the man understands that even with those conditions in place, 75% of men on active surveillance eventually need active treatment. That's a narrow set of conditions. In my experience, most men on active surveillance don't meet all three. The cancer is low risk, but the plan doesn't have a defined stopping point. And that gap is where cancers like Stephen's change grade before anyone acts. So here's what to do with this. If you're on active surveillance right now, ask your doctor 2 questions at your next appointment. First, what is my trigger threshold? Get a specific number or a specific biopsy finding written down. Second, am I a candidate for brachytherapy? Those 2 questions will tell you everything about what kind of plan you actually have. If you're newly diagnosed and being offered active surveillance, ask both of those before you agree. A good surveillance plan can name its own stopping point. If the answer is vague, push. And if you're a candidate for brachytherapy and you didn't know it, you now know what to ask for. One visit, one morning, a 98% cure rate with most of your quality of life intact. That option exists. Most men just haven't been told it does. You walked into this video thinking active surveillance was the cautious choice. It can be, under the right conditions, with the right plan. But for most men, brachytherapy is the path that ends the uncertainty in one visit with a higher cure rate and a better side effect profile than the alternatives. The decisive question is whether your plan has a defined stopping point or whether it's just watching and hoping. If you've ever wondered what the signs are that your active surveillance plan has no real stopping point, watch this next. It's called 5 Signs Your Low Risk Prostate Cancer is Being Managed, Not Treated.